I usually teach 112, but this summer I am helping and assisting teaching 114. So this is new for me, and I like it. Get me out of my norm of 112. So you get to 114, you kind of see how you all have been just advancing up the realm of nursing school this week. So y'all agree with that? Y'all are more mature than you were when you were in 112, right? Of course. Yes.
Maybe.
Yes, you have, you have. So actually, we're gonna talk about psychosocial, the psychiatric portion. And this is like a real fast-paced course. It's funny, because when I was in nursing school, where you are now, when I was in nursing school, Psych was like a whole semester. Semester. It wasn't quarter then, it was semester. It's a whole semester. So now y'all are just getting it all in, what, 5, 6 hours, so, but.
Make it a little bit easy, please.
Make it a little bit. Well, if you just get the gist and listen to me, then I think you'll be okay, okay? So the first thing I want to tell you is that when you study, you have your Saunders book, right?
Yes.
Chapters 65 through 69 covers a lot of the psychiatric information, okay? Now, I would advise you to really study this Saunders, okay? Because, of course, doing testing, we can't test you on everything, right? But you never know what you might see on HESI or when you get to your NCLEX. So you need to make sure you go through and study these, okay? Also on the module, I also had the free book that you can look at to kind of reinforce your information, okay? So another thing I would advise is that listen as I go through my PowerPoint, okay? PowerPoint, what you're gonna do for the test is go through my PowerPoint, all the things that we've discussed. That's gonna be a majority of what's on the test, but however, Saunders helped bring all of that together. So I would advise you to go through the PowerPoint and then reiterate all of that with Saunders. And you're gonna see that Saunders is gonna talk about some things that I might not discuss, but you never know when you're gonna see that information again, so you just need to make sure you touch on that too, okay? Any questions on that? Okay, so let's get started. We're gonna talk about psychosocial.
Dr. Carter,
Yes.
I'll tell you, it's not working on me, I'm
What?
not sure.
Are you
I tried to say
kidding?
that earlier until just now.
Okay,
I went through my lecture, I had to start using the keyboard.
Do you want me to bring mine down? Cause I have my own.
you got one? Wait, I might have one. Hold on. I think I got one then.
Maybe the battery.
Yeah, it may need a battery.
Here, I'll pick it up and replace the batteries on it.
Okay. I feel like I need my six. This is a trigger warning. So what the trigger warning is if it's anything that we may discuss, okay, that you feel like I just need to step out a minute, I need to revamp, I need to do this, please feel free to. Because sometimes, talking about psychiatric stuff can kind of ruffle some feathers of things. So just let you know that if you feel like you need to step out, you can do that, okay? For as objectives, these are the objectives that we're gonna hit during the time. We're gonna talk about some disorders, we're gonna talk about treatment, we're gonna also talk about how we take care of these patients. Has anybody in here been to a psych clinical yet? Wow, just about all of you. How did you like it? You did? Okay, cause that's perfectly fine. Cause some people, either you like it or you don't, okay? So when I was in nursing school, guess what? I almost quit nursing school because of my rotation in psych. I did not like it. And back when I had to go for the rotation, it was that people were locked in a room and we had to go into the room, be locked right behind them, and all we had was a beeper if we needed help.
Oh, no, ma'am.
When we talk about phobias, that did it for me. I was like, I cannot do this. And so it just happened that my instructor said, Chandra, just take a deep breath. We can make it through this. If I wouldn't have had her to pull me on through, I probably wouldn't be here today. But guess what? Now I love it. Who knows? After some years, you may start to like it. And one thing about it is I don't care where you work, guess what? You're dealing with psychiatric issues, okay? So let's take a look at this. This is just a little introduction. So what is your thought when we talk about mental health? What's the definition of mental health? What would you say? What's your definition? Or what do you think for as mental wellness? What does that mean?
Is that like a stable state of mind?
Stable state of mind. So when you say stable state of mind, what does that mean? Well, I have to be able to do my chores from day to day, okay? Now, how many of you, is it anybody in here that's not stressed right now? Okay, that's what I thought. All of us are stressed, right? But are we able to work from day to day and doing what we need to do? We can cope with stress. And nothing's wrong with stress, okay? Nothing's wrong with stress. Where the issue comes in is when we're not able to cope with stress. So when we're not able to do those stable things, that it comes into place that it is hindering our work, it's hindering our school, it's hindering our relationships with people. That's when we need to look at mental illness, okay? So just having a little stress, it's okay, it's all right. It's really keeping you on your toes of what you're doing. But the issue comes in when you're not able to deal with things, okay? And that's where we see mental illness being a problem, okay? So mental health, CDC says that it's the emotion, psychological being, how we handle our stress, how we relate to others. The WHO World Health Organization, they label mental wellness as the state of how we cope with stresses of life, work productively, and contribute to our community. Everything we do or have is wrapped up into our mental being. So again, relationships, our occupations, interactions with our friends, interactions with our kids, our family, our significant others, okay? All of that's wrapped up into our mental wellness. So when we talk about mental illness, it is a clinically significant disturbance in an individual's cognition, in their emotions, regulations, or behavior, okay? So when we talk about mental illness, we don't want to really, I think we take a lot for granted, because when we look at mental illness, there are a lot of people who are suffering from mental illness. A lot of people. And I hate to say that mental illness is one of those things that we overlook. Because when you look at the state of Alabama, how many places do we have that's open for people with mental illness?
Not enough.
Not enough, okay? What do we do about it? Because look at all the people who are incarcerated. Do you think that they're really incarcerated because they really were evil people and wanted to do something bad?
Oh,
Some of them, yes. But then there's some of them, could it have been a mental thing? You think? Yeah. Okay? So if we really had a grip on people of taking care of people with mental illness, it might be a little different in the world. Okay? That's just my expectation. That's what I think. Okay? So how do we assess? Okay, so when we assess our patients, most of the time we're doing a head to toe, right? We're doing a head to toe assessment and we're looking at alert and oriented times 3 or 4. We see that their pupils are equal, round, reacted to light, all of those things. But when we talk about assessing psychiatric or mental issues, what are some things that we're gonna clue into more than just head to toe? Well, what are some things we may clue into? But when we look at cognition, some things we can think about with cognition, are they experiencing anything like delusions, hallucinations, or their disorganized thoughts? Because sometimes you can see a person and they're sitting there and they look fine, and then you start to talk to them and it's like, what are they talking about? Okay, that's an issue, could be an issue with cognition. So, first of all, what does delusion mean? For someone to be delusional,
Altered reality.
altered reality, something that's probably false. So if I say I am the Queen of England and I need for you to respect me like that, first of all, y'all gonna look at me like I'm crazy, right? Because I am by no means the Queen of England. That's a delusion, okay? That's a delusion. On the Psych unit last week, we had a patient. Thank you. Oh, okay. Yes, yes. Thank you, Dr. Stokes.
You're welcome.
I'll see you. Bye. So we had a lady on a Psych last week, actually the last 2 weeks I was there. And one of the things she said is that she has come up with a cure for HIV. Y'all see, okay. HIV 1 and 2, let's put that in there, HIV 1 and 2, okay? That is a delusion, that is a delusion. And she really needs to get out of there because she's got so much she just really needs to do, but she's stuck there and she needs to get out there, okay? And something else about an airport. She was talking about the airport, that there's a big airport in Lynette, which there is a little place in Lynette, but it's not like in Atlanta. But she needed to get on the plane and she needed to go and take care of business. That is a delusion, okay? Hallucination. Hallucination can be auditory, it can be visual. Oh gosh, it is 10 bats up there, y'all. Look, 10 bats. That's a hallucination. Or I can hear voices, okay? That's an auditory hallucination. So delusion is something that's strictly false. Hallucination is something that I see or I may hear that's really not there, okay? So when we talk about emotions, we assess emotions. This has to do with seeing how a person reacts on the outside to match the inside, okay? So, for instance, I'm not feeling, I'm not feeling well. I'm not feeling well today. Well, does that match how usually you would act if you're not feeling well? Would you be laughing about it? No. So I'm sure y'all look at me like she is really on top of it. But when you think about emotions, emotions has to do with, is it in concurrent with how that person really feels, okay? So for instance, labile. If there's a patient who has labile emotions, L-A-B-I-L-E, this means that they cannot regulate their emotions, okay? So when we get into talking about patients who are manic, this is where we may see this type of emotion. Some people you may see with a flat affect. So, I am just teaching y'all about psych. And I want y'all to know everything it is to know. Flat emotion, flat emotion, flat effect. That's what it is. You really don't know whether they're happy. You don't know whether they're sad. You can't make it out. Just a flat effect. Okay? So let's look at the behavior part. We're going to assess the behavior part too. So I'm just so, oh gosh. Y'all, we're going to talk about this stuff. We're talking about behavior now. Oh gosh. Woo! I'm just itching everywhere. Okay? That could be an example of anxiety. Okay? So when we look at behavior, how does that person act socially? Social anxiety is a big thing now, social anxiety, okay? So we are coping with our anxiety that we have, but some people cannot, and it begins to show in their behavior, okay? Let's look at some cultural considerations. Now, every culture has opinions or they have some type of stigma about mental health, okay? Sometimes we say if someone is having mental issues, they're just crazy. That's a stigma, okay? There are issues that can occur emotionally, behaviorally, cognitively, that can affect a person, okay? But does that make them a bad person? No, it doesn't. They just need help mentally, okay? Sometimes if you have mental health issues, it may feel like a sign of weakness. So why do you think some people who know that they are having issues but don't want to seek help, why do you think they don't want to seek help?
Want to be labeled.
They'll be labeled as what? Like I said, crazy. They're crazy. That's just one example. They'll be labeled. What else?
It might affect their career.
Can affect their career. Most definitely. Yes. All of these things play a part. So when we talk about symptoms, this can affect how someone describes their symptoms. Okay? When we talk about support, that can be challenging because with this person that's having emotional issues, do they have the support that they need for as someone to help them stay on their medications, to make sure they get their medications, to make sure that they go to their doctor's appointments. And then for as resources, it's hard to find, like I said, we said earlier, mental health care, especially if it's more specific to something, it's hard to actually get those resources out there that we may need, okay? So do we have a true support system? Does that person have a true support system of someone who can monitor them, can take them to their appointments if they need it, to help them with their activities of daily living if they need them? That's something we need to consider. So when it talks about causes of mental illness, now, as far as research, we can't truly say that there is like one or two things that is specific to why people have mental illness. We do have some suspects of what could lead to it, but we don't know it definitely, okay? So these are some things that we look at. When we look at environmental, sometimes we can look at the social determinants, and that could be a reason for someone having mental issues. So say for instance, if someone has lived in poverty all their lives, they've had to fight for everything, food and get those things because they've lived in poverty. Discrimination can be one, racism is another, or violence, okay? So if you have been involved with some type of violence in your life, then that could be the reason of some mental illnesses like post-traumatic,
PTSD.
PTSD, thank you, sure, yes. So that could be a reason. PTSD doesn't just happen to people who has been in the Army or armed forces. Depending on what has happened in your life can put you through a sense of PTSD. Adverse childhood experiences. So what do you think would fall in that? Adverse childhood experiences. That could be abuse. That could be neglect.
Loss,
What's that?
like loss of parents.
Loss of parents at a young age. You're exactly right. Abuse, neglect. We also see some things like incarceration, growing up with abuse in the home. And according to statistics, it says that 61% of adults have experienced some type of abuse in a home or have seen abuse. 61%, that's a larger number. So what happens is it can change the brain development and how the body responds to certain stress. So that's how we come up with those environmental things, social determinants and the ACEs being an issue. When we look at biological, this has to do with neurotransmitters. So we have different type of neurotransmitters in our brain. And if one of them is affected, it could cause mental illness. So we have dopamine, we have GABA, we have norepinephrine, and we have serotonin, which are like the top transmitters. Dopamine is responsible for learning. It has to do with emotions, our executive functions. Now the GABA neurotransmitter is an inhibitory neurotransmitter. It slows down excited nerve cells. Norepinephrine stimulates alpha and beta receptors. So norepinephrine has to do with our stress, helps with stress. It helps with our sleeping. It helps us to focus. Serotonin has to do with our mood, sleep also, libido, and our temp levels. So if we have any type of disturbances in these neurotransmitters, that can cause an issue. And then genetics. Now genetics is not well understood, but if someone in family has a mental disorder, it can be someone else in the family that may experience that same disorder as well. Now, have we proven that to be true? No, it's not proven 100%, but this is like a speculation. So then when we go into our complications, here we go. When we start having these type of issues, some of these issues, this is how mental illness can be a detriment on our lives. First of all, relationships, it can affect and may become detrimental. So for as relationships, again, if we have abuse in the home, if we're in a relationship with our significant other and they're abusive. Now when we say abusive is not always physical, okay? Abuse can be what? Emotional as well, which to me is kind of worse than physical, but that's just my thing. But yes, complications in our relationships, functional ability, when you are not able to perform your activities of daily living. What type of disorder made you see that in more than none. Anybody have an idea?
Depression, major depression.
Depression. Major depression. Major depression. You don't feel like doing anything, you don't feel like interacting with people. All you wanna do is sleep. Well, some sleep and some don't get sleep. But you can sleep a lot, you don't have any energy to do anything. So things go lacking, even in our hygiene, in our drive to do anything. Socioeconomics, we start having some mental issues, then that could affect us holding a job, right? So think about us as nurses. Let's just think for a few minutes. What could be some issues with mental illness that could deter us from keeping our job as a nurse?
Proper judgment.
Yes,
I mean, if you can't do proper judgment, then you can't perform the job.
right. How about substance abuse? Why do we have to count the benzos now when we get medications for a patient? What's the real reason why we need it, why we have to do that? What is one of the reasons we have to do that?
If somebody else had a problem, start taking them,
Yes,
made them feel better.
yes. So when we look at things like that, it can get in between your job, okay? So that is an issue. Mental illness can also increase medical disease. So when there is a mental illness, it's more prevalent to a person having stroke and having heart disease. And then, of course, increased risk of death. Because what do we see with mental illness? A lot of people have issues with suicidal ideations. Not only suicidal, but homicidal. Okay, it gets to go that far. I don't know if y'all remember, and y'all may not even know, but it was, I guess it's been about 4 or 5 years now, it hasn't been that long. But, there was a nurse, very prominent nurse that worked at East Alabama, that, she was actually like in charge of the emergency room, at that time. But there was some mental illness, with her brother. And so one day, she was at home and her brother went in and killed her. I don't know if anybody remember that. Yes, and this was like 4 or 5 years ago, it hadn't been too long ago. And to this day, I don't guess we really know what actually happened, what triggered him, but we do know he had some emotional instability. But yes, she was a very prominent nurse that worked at the hospital. And she was taking care of him, she was taking care of, you know, a lot of her family members, but yeah, that happened. So that was like a distraught to the East Alabama because it happened just all of a sudden, just one day. So when we talk about mental health, it's real and it's out there. And it doesn't have to just be that someone is suicidal is suicidal. It can either also lead to homicidal, okay? Any questions with that? Okay, so let's talk about diagnosis. Because just because I'm anxious today, that doesn't put me in the category of having anxiety for the diagnosis. So when we look at being diagnosed with a mental disorder, it has to be over a certain amount of time. It has to show more than just one thing to say that I really have an anxiety disorder. So we're gonna talk about that too when we get into the disorders. So when we look at diagnosis though, the DSM, which is a Diagnostic Statistical Manual, that's the manual that psychiatrists use for its diagnoses. Now, first of all, if I come in with some type of hallucinations, maybe hallucinations or, let's just stick with hallucinations. Does that mean that I might be a schizophrenic just because I'm having hallucinations? Or could it be something having to do metabolically?
Absolutely.
Yeah. So before you can say I'm a schizophrenic, we need to look at the whole picture, because my hallucinations or whatever may not be because I'm mentally ill. It could be because of a physical thing, okay? So I could be where I'm having acute kidney injury. And when you have acute kidney injury, sometimes patients can start having hallucinations because all those poisons are in their body. So these things can happen. So we have to make sure that we look at all the other areas before we can say that this is a true mental issue, okay? So in that case, we would want to make sure we do labs. We make sure we want to do labs. Of course, your electrolytes. Is it a potassium imbalance? Is it sodium imbalance? What is really going on? So we're going to look at our labs. Another thing that you're going to see, and if you looked in the charts when you were on the Psych unit, if you really studied the chart and looked, you're going to also see that they're going to do what type of labs? Y'all know?
It starts with, lithium.
Yes, if they're on lithium, they are. But they're gonna look and see
For
if
substance.
drug substances. Yes, because if you look at the substance and if they've been on heroin, that could be a reason for their hallucinations or their delusions that they're having. But we need to know that first before we actually say they're mental. Does that make sense? So we need to look at the physical aspect just to make sure before we put them on that psychological diagnosis. Also, we want to do, for as imaging, we want to may do brain scans, look for tumors. Because if there's a tumor and it's interacting with the brain some type of way, that can cause some of these symptoms that we may see for as illness. So let's talk about treatment. There are a lot of type of treatments that we do. There's multidisciplinary treatment where we consider a lot of disciplinary groups to help with their treatment. We can start with a psychiatrist. We can also have a psychologist. We can have counselors, which if you were at East Alabama, you did see these people there. And when we think about therapy, there's different type of therapies that can be used. Now, as a nurse, we want to make sure we provide a milieu environment. A milieu environment. M-I-L-I-E-U. Make sure you know that. M-I-L-I-E-U. That is a safe environment for the patients. To make sure they have a safe environment, they're there with people they trust in order to provide therapy for them. We may have behavior modification therapy done, where we may reward for reaching goals to get better. So say for instance, especially in the pediatric portion, sometimes we may use that. If a child wins a game, say they win a game and they have anger management problems, but they lost the game, but then they accepted that and they didn't get angry, then we may use behavior modifications for that. That's just an example. We also have electroconvulsive therapy, where we trigger the brain and try to snap the brain into a different way, so to speak. There's so many different type of electroconvulsive therapies. And a lot of times that's kind of like one of the uses of kind of like last resorts, because of course when you're using electric currents, that can be detrimental too. So you wanna make sure that you do all you can before we actually get to that part. So what we see a lot of times for as treatment, we first wanna start with medications, therapy and medications is where it's pretty much gonna fall. Now, when we talk about medications, this is where it becomes an issue too, because a lot of medications that we're gonna discuss, some of them can make you feel more horrible than you feel it. But they do help cut down on some of the symptoms that a person may have, or it may help with the hallucinations, but then they feel like crap, even worse. So when you look at medications for psychiatric disorders, sometimes it's a win-win situation. And that's one reason a lot of people, I say a lot of people, but some people stop taking them because they say it makes me feel worse. But what are we trying to stop here? We're trying to stop you from having these suicidal ideations, the hallucinations, those symptoms. If you don't take your medicines, that can't be controlled. So it's like, darn if you do, darn if you don't, okay? So when we talk about guidelines for mental health care, one of the things that we want to do is make sure we respect our patients. Respect them. And one way that I look at it as being, doing psych rotations, or the way I look at it, when I'm turning it back on me, is that it could be me in there. So that helps me to understand more why I am trying to help that person, okay? Because we talked about earlier that it can, that it's like stigma can be put on it. But I know that it could easily be me too, so that helps relieve the stigma that I would put on a person because they're having these issues. So we need to respect people. We also need to use effective communication skills. This is very beneficial in psychiatric patients, is using therapeutic communication. You've talked about therapeutic communication even in 112, okay? Communication is very important. And in a second, we're gonna talk about some different methods of therapeutic communication. Establish a therapeutic relationship, which means that if you see that, and you believe that I'm a good person and you feel like you can talk to me, then I'm gonna establish a therapeutic relationship with you. But if I see you one that looks like going out talking about me, am I gonna express to you really how I feel? No, I'm not, okay? So as nurses, we've got to realize that it's important to establish that therapeutic relationship. Because if you don't, then you're already behind the 8 ball of trying to help that person. And then conduct a comprehensive assessment in order to help provide care for the patient. So some other things we want to do is we want to make sure we protect confidentiality. We've heard that from day one, okay? Do not ignore when they're talking. And then ask questions in ways that they can understand. Okay, so just at the bottom of this slide, let's just talk quickly about how a person is admitted to a psych unit. It can be voluntary or it can be involuntary. Okay, voluntary means that I can go right now, and if I see I am having some issues, I'm really going through some deep depression right now, I can go in there and say, I really need some help. Voluntarily, I need help. So I went in and I signed myself in, and then I can sign myself out. Involuntary commitment means that I have posed the threat to myself or others. So if that's the case, then I can involuntarily be committed to a psych unit, okay? And then depending on the state, it just depends on the state. Sometimes it takes 2 physicians to say that this person is, needs to be admitted. And then also the court may get involved, okay? And they may say that this person needs to be committed for treatment. So that's involuntary. So what I want you to know from that is that it can be voluntary or involuntary. If voluntary gets to the point of you causing harm to yourself or to someone else. Okay, so this is where we pick up with therapeutic communication. These are different type of communications that you may use, and I hope when you did your rotation, some of you probably did it and didn't even realize that you were actually doing therapeutic communication. But I hope you use some of these things to talk to some of the patients, okay? First, let's look at acceptance. Acceptance is just acknowledging the person's emotions. So for instance, the patient says, I hate taking all of these medications. But then I may say, yes, I understand. I understand it's a lot of medication. But it's really helping you get better. I can see that you're getting better from taking it. Okay, that's acceptance. So when we look at clarification, restating, and paraphrasing, this is a big one. Because the patient may say something like, I feel useless. I feel really useless. I'm no good for anybody. And then I may say, to clarify that or restate, I may say, explain to me what you mean by you're useless. Give me an example about what do you mean you're useless. Focusing is when you draw attention to a specific thought. So the patient can say, I don't understand why I need to be on this diet. Why do I need to be on this diet? And then me focusing back on that to them, I may say, you seem concerned about changing your dietary habits. Tell me what your concerns are. I'm focusing in on that one thing about the diet, on the diet itself. Exploring is when you want them to give you more information. So I can say, I have a dark secret. And then you're gonna say what? Ah! No, what I'm gonna say for is exploring, tell me about your secret. What's your secret? Tell me about your dark secret. Now, why would I do that? Why would that be therapeutic communication? Because first of all, is this real or not real? Well, it's real to them. But why would we want to use that to say, tell me your dark secret? Think about the safety.
For yourself and other people.
Do what?
I mean, if they tell you, oh, well, you know, I have this secret to kill everybody, then.
Thank you. And we say, well, tell me your dark secret. And you tell me that, then it may be some measures we need to think about putting into place, right? Because if this patient is mental, what could happen? They could put this stuff into play, all right? So it's not that we are agreeing that they have a dark secret, but what are they thinking? Because we may need to put some safety measures into place. You're exactly right. Okay, giving recognition. I noticed you took all your medications today. That is awesome. That's great. That's giving recognition. Now, one that is used a lot, and not just in psych, on the psych unit, but any unit you work on, open-ended is very good, open-ended. And when I say open-ended, that has to do with not just being yes or no, is people elaborating, talking, okay? So that means that, tell me more about your concerns. Tell me more about what's going on with you. That's more than just a yes or no, should be more than just a yes or no question. So it's getting more information out from your patients, which that's what you wanna do. Presenting reality. Now, for instance, a few minutes ago, when I said that I see 10 bats back there, presenting reality is you say, okay, you see 10 bats, I don't see 10 bats. That's presenting reality, okay? That's presenting reality. Reflecting is to help to come up with own solutions. So do you think I should take this pill? Reflecting says, well, tell me some pros and cons of you not taking this pill. It's putting it back on them to decide whether it's right to take the pill or not, or if it's best. Providing silence is one because you don't always have to speak, you know. I know a lot of times we think we have to be talking, but sometimes people just want you to stand there. Or just silence and just eye contact of listening, okay? That's very therapeutic. And again, that falls to offering self, where we're just there present. Offering hope has to do with just encouraging, okay? I remembered you told me how you cope with your anxiety. That's offering hope. Of course, humor is always good to lighten the load. Sometimes you have to be mindful about humor because today I might not be in the mood for anything funny. You know, you have to have that mood or know when is the best time to use humor. And confronting, again, is kind of like presenting reality, okay? It's about the same thing. Now, let's talk about some non-therapeutic responses. Out of all these things, one thing that you don't want to do is ask why. Why did you do that? Why are you not taking your medications? What does that sound like when I ask you why? Yes. So you don't use the word why. For what reason is better? It doesn't sound as like I'm being defensive, okay? So you don't want to use why. You don't want to ask personal questions. So if they're not relevant to what you're actually trying to do to treat the patient, you don't need to ask them. Stay very professional. And you don't want to give personal opinions. Well, if I were you, this is what I would do. No, you're not in my shoes. So really, you don't know what you would do, okay? So giving personal opinions. And you don't want to change subjects. So if I'm talking about one thing and then you're trying to change the subject, let's make it seem like you're not interested in what I'm talking about. Again, a therapeutic thing to do in that case is just silence. Just express what you're expressing. I have my opinion, I'm listening, okay? And approval and disapproval has to do with not our place to give moral attitudes. So, for instance, I don't approve of you smoking a pack of cigarettes, okay? Again, you're not me. And then as nurses in general, we can't be passive, but we shouldn't be aggressive either. But we should be assertive. So what's the difference? Assertive is right there in the middle, okay? So for instance, if if the patient says that, I don't wanna get up out of the bed today, okay? What can I say as the nurse to be assertive and not so much passive or aggressive? What do you tell your patients? Anything? Well, I understand you don't wanna get out of the bed, but if you get out of the bed, that's gonna help with a lot of things, okay? One thing, we don't want you to get pneumonia. And if you lie in this bed, you may could get pneumonia because you're not getting up, moving around, okay? That's being assertive, okay? That's the difference. Okay, so let's look at this for a minute. This has to do with therapeutic communication. So let's look at this video.
Is it true that medications like gabapentin could actually be pushing people closer to amputation?
Absolutely, and it
Hi, can you tell me your daughter's name?
Kate Murphy.
And what's her date of birth?
She was born on August 20th, 1987.
Okay, good, that's what I have here also, okay, good. So, what's she here for today?
Your name's Kate. She'll tell you.
Oh, okay, why are you here today?
So I recently moved back into the area and I'm looking for a primary care physician, just someone for those day-to-day sort of pieces of things. I've also kind of had this sore throat for the last week or so, maybe 10 days.
Okay, a sore throat, okay, 10 days, about how bad's the pain for the sore throat?
It's pretty bad. I mean, it's definitely interfering with things.
On a scale of 0 to 10, if 10's no pain and, if 0 is no pain and 10's the worst pain you've ever had in your whole life, what would be the pain, would you say now?
I'd say it's probably around like a 7 or so.
That's pretty bad.
Yeah.
Anything making it better?
Nothing's really making it better. I'm taking Tylenol about 2 to 3 times a day, but I'm really getting no relief from it,
Okay.
unfortunately.
Anything making it worse?
Nothing really making it worse.
Let's see. That's probably about all we need to know about the sore throat. All right, anything in your past medical history that we need to be aware of?
When I was 5 years old, I was in an auto accident, so.
Oh, that's not really related to your sore throat though. Anything about your sore throat?
I mean, nothing else about my sore throat, no.
Okay. All right, so let me check your vital signs, and see how those are doing. And then the nurse practitioner will be in shortly to check out your sore throat. So I'm just gonna take you over to the blood pressure cuff here. Oh, sorry, that chair's in the way.
I mean, I'm totally fine doing this myself, I can push.
Well, you know what, I'm here to help you. That's my job.
I know, but, you know, I'm good at wheeling this.
So let me check your temperature first. I'm gonna put that under your tongue. Okay, 98.4. Her temperature is really good, that's normal. And I'm gonna just check your pulse here. All right. And her pulse is normal too, that's 84. And then last, blood pressure. And blood pressure is normal also, 100 over 60. Okay.
So just from that,
Fired.
Huh?
Right.
Fire. What are some things you saw?
She was talking with her mom, and it's a grown lady too, like, she's not a
Yes.
child, in the wheelchair, she didn't let her do it.
Right. So she came in talking straight to mom. Well, hello, I'm the patient. What else did you see?
She she also reported back the vital signs to the mom instead of the patient.
Yes.
Like you're working on her and you're talking to her mom.
Yes, and what was it that she said, well, that doesn't have anything to do with your.
Or car accident.
It's
She's
like,
not giving
really?
psychosocial.
Yes, okay, so those were some things that can really just set your patient off from the start, like, I don't even want you in my room. Now, how many of you would like a nurse like that if you were the patient? No, no, okay? All right, so, let's go back and let's look at this one. Well, what happened to it?
Oh my gosh, perfect, yeah.
Good morning. I'm just shutting that door so we have some privacy. And I'm gonna wash my hands here real quick. I'm Jennifer Ross. I'm one of the nurses here in the office. What's your name?
Kate Murphy,
Hi, Kate. And what's your date of birth?
9/28/87.
Okay, and good, that matches what I have on your chart, so
Great.
that's great. Nice to meet you. And who
too.
did you bring with you today?
It's my mom, Betty.
Hi, Betty. Nice to meet you.
Nice to meet you.
I'm just going to ask you to step out to the waiting room for a few minutes while I just speak with Kate privately for a couple of minutes, if you don't mind.
Okay.
Thank you. And the waiting room's right out that door. So pull up a chair here. So what brings you to our office today, Kate?
So I moved into the area recently and I'm just trying to get established with a primary care physician. Just want to have somebody in the area that I can touch base with. I've also kind of had this sore throat, so I wanted to come in and have that checked too.
Okay, sounds good. So about how long have you had this sore throat?
I think around like 10 days or so.
Okay.
Along those lines.
So it's been going on for a while.
Yeah, I think we only kick it.
Okay, probably a good idea to get it checked out.
Absolutely.
Has it been going on pretty consistently, or does it come and go?
It's definitely been pretty consistent.
Okay.
Again, I can't get rid of it, so it's just something that's like really lingering.
Yeah, probably a good idea to just make sure there's nothing going on there. On a scale from 0 to 10, if 0 is no pain and 10 is the worst pain you've ever had in your whole life, what would you rate that pain at right now in your throat?
Not a 10, but I'd say around a 7 or so.
Oh gosh, so it's pretty bad.
Absolutely.
Is there anything that makes it worse?
Nothing that makes it worse necessarily, but I've been taking Tylenol about 2 to 3 times a day just to
Okay.
kind of help with it.
Okay.
But again, that's not really completely helping.
Okay, it's
not going away.
The Tylenol's not doing a whole lot.
Not really.
Okay, all right. So when the nurse practitioner comes in, she'll definitely take a look at that throat and see if there's maybe anything else that we can do to get you a little bit more comfortable
Okay,
there. I noticed that you're in a wheelchair. Can you tell me a little bit about what happened?
Sure. I was in an auto accident when I was 5. I'm a C7 T1 quad. It happened in October of '92, so a long time ago.
Okay.
But paralyzed chest down.
Okay. And how does that affect your daily living, your activities of daily living?
For the most part, I'm pretty independent. I have some care that comes in, but usually, in the whole, I'm independent.
Okay. And do you have any other pertinent past medical history that we need to know about as your new providers?
When I came in this morning, I gave you guys a piece of paper with other surgeries, a list of prior surgeries,
Okay.
so it should hopefully be in there.
Oh, yep. You know what? They have it right here. Perfect.
Great.
Thank you so much. Okay.
That's always helpful.
Yes, it is. And you know what? That way it's all written down
Yep.
and we have it right on your record. Thank you so much.
Yeah, of course.
And do you have any allergies? Anything that you're allergic to that you know
Nothing that I know of.
of? Okay. Any medications that you're taking besides the Tylenol right
Nothing
now?
other than the Tylenol.
Okay. And
So what's your thought on this one?
17.
That's a big difference, right? Because first of all, she came in and what did she do when she came in?
She introduced herself.
She introduced herself for one, and she kind of told her what was going on, let her know confidentiality, all of those things. So when we look at these therapeutic communication, that's really what sets the tone between you and your patient, especially on the psychiatric unit, okay? It's really what sets the tone. Are you coming in and not being friendly and all of those things, or are you coming in and introducing yourself, all of those things, okay? All right, so let's look at safe care environment. Again, you see this word, milieu therapy, providing, safe care for the patient, okay? Now, when you went into the psych unit, what were some differences you saw in the aspect of that unit compared to going into like a med-surg unit? Was there anything you saw different?
It was locked down.
Locked down, yes. Where else?
It was really relaxed. They were all just kind of in that room, like coloring and interacting.
Okay. What did you see about the room itself? Did you go to like one of their rooms?
Beds are both down.
What about the beds?
They're bolted down.
Yes, they're bolted down.
They had tearaway, shower curtains, and they had paper trash bags.
Yes. Why is that?
Safety concerns.
Yes. Okay, so did you see any, how about the mirrors?
They kinda look like
They're not
a
breakable.
jail cell. I mean, like,
Yes, yes.
There's nothing there you can injure yourself on.
Exactly. So that's one of the points, is because the number one thing with these patients is safety. So we can't provide things to them that's going to cause that. So when you, once you went out on the units, when you went out on the units, what all did you have? Did you take your pens? Did you take your notebooks? Did you, no, okay? Because you don't want them to get something that they can use, to hurt themselves or hurt others, okay? So when they get their trays, even when they get their trays, they don't have metal, utensils on them, okay? Cause they could easily, maybe stab something, right? So they don't have those things. So milieu therapy is when we're providing that safe environment for them. Another thing to be careful with is our boundaries. Now, we have to have a nurse-client boundary, which means that we are there to help the patient, right? And we cannot get into, we need to have boundaries. Because what you will see is some of these patients, and some of them, now I'm just saying some of them, they've been good with their illness for a while, that they can try to manipulate you, or they can try different things. So you have to have that boundary with, I'm your nurse, I'm taking care of you, and that's the boundary, okay? So you have to make sure of your boundaries, how you treat your patients. Because if they see that you treated one and laughing with one and you're not laughing with me, that's not good. So you have your boundaries, okay? Make sure of the space. Make sure of your space, all right? Give them their space and they should give you your space. So when we look at assessing a risk, the risk that we want to, of course, assess is patient safety. So a patient safety screen is used. So for those of you, I don't know if some of you work in the emergency room, but sometimes when you have patients that's coming in and they're having issues, for as mental issues, and not only them, they're asking any patient, have you had any thoughts of suicide, right? So they place that, they do what we call adult suicide screen, and a suicide screen to screen whether the person has had suicidal ideations or not. If that person says, yes, I've thought about killing myself, then there are some measures every facility has that you should do in that case. One may be that if they're in the emergency room, then they're gonna be on one-to-one observation, which means that there's gonna be someone watching them at all times, one-to-one observation. Does anybody work in the emergency room setting? Okay, they will put you on one-to-one observation. Safety plan has to do with, say if you have a patient that has come in and have had suicidal ideations, you can make a safety plan with that patient to, it's like an agreement, it's like a contract. that says that, that you're not gonna harm yourself. Sometimes this works, because if you see that I'm talking to you about this and you agree this plan, hopefully you know, won't follow through with it. So that's something that's also used. Again, prevent workplace violence, which is on any floor that you're on, not just Psych, but you wanna make sure that, you do things to prevent, workplace violence. So, when we talk about things that we do to try to prevent or try to cause safety, or so it won't be workplace violence, even when you look at how we ask you all to dress safely, because you wouldn't want your hair hanging down, right? Because what could someone that has a manic attack do? Well, snatch your hair. How about earrings? If I had some hoops in my ear, they can snatch those, okay? You should have gone out on the unit with a stethoscope around your neck, right?
You should have?
You should not have.
Oh. no.
Because if so,
They have
what could have happened?
Strangling.
Yes, so you see that these things that we ask y'all is not just because we mean, but these are things that we know that can cause injuries to, especially youth. And we don't want these things to happen. Okay? All right, so let's talk a little bit, what time is it? I'm gonna give y'all a break. We'll talk about this and then we'll take a break. Okay, legal and ethical considerations, which we've talked about in 112, so it's nothing we really need to harp on. But you need to remember these things, because when, even though we have patients on any unit, whether it's Psych or anywhere, but sometimes, well, we are not to hold them hostage to anything, okay? So what does it mean when I say false imprisonment? It means causing a person to be confined, okay? So one of the things when we talk about legal and ethical considerations, not only on Psych, but on any floor, is what is our last resort when it comes to a person being unruly? Restraints, okay? We don't want to get to that point, okay? So even last week on Psych, and this was on Psych where we think that you pull out restraints anytime you want, practically, if they start acting up. But the nurse said, well, I'm trying to do everything I can, because this patient had become very, very rude. To the point that she had gotten to the point that she hit one of the security guards. Yeah, so it had gotten to that point for her manic stage. But even then, they didn't want to put her in restraints. So they did give her some medication to help calm her, and it calmed her down fast. So when you look at legal issues, this is something we have to think about for as nursing, because in any area, we still want that last resort to be using restraints, okay? We talked about the involuntary admission already. And we talked about the privacy and confidentiality, which we know with any patient. And so let's talk about duty to warn and protect. We as nurses have an obligation to report certain things. Okay, so if we see that someone has been abused, we assess that patient and we see that it could be possible, there are certain things that we should report. Okay, so that's, even though we say confidentiality, but still there are some things by law that we need to report, okay, that kind of falls out of that. And mandatory reporting, of course, is that same thing where we need to report certain things. If we see that a child has been neglected, or we see an elderly has been neglected, and they come in and you see wounds all over them, and you see they have tons of bed sores, that could be a big sign of neglect if they've been living at home with someone. So those are the things that we need to make sure we report. Now, when we talk about the nursing process, here we go. This is an example of what? What theory? Maslow's theory. Maslow's theory. And when it comes to psychiatric patients, where are they on the Maslow's theory? Right in here, okay. Yeah, they need sleep, they need some of these things, but we should be out of the physiological aspect. We should be here as an issue that we're trying to provide for them, okay, safety. So again, that's where it comes in with those different types of screenings that we have to do, all of those things to make sure that this person is, falls in this realm of safety. So when we look at prioritization, by usually Maslow's, it is safety, okay? SMART goals are specific, measurable, attainable, reachable, with time goals that we can, reach, okay? So outcome, when we talk about outcomes to safety, what are some things that, what is some of our goals? But how can we meet those goals? And we don't want our goals to be so general. So say for instance, if I say I want to walk 2 miles, okay, that's kind of general. How can I make it more specific? Well, when do I want to start walking these 2 miles? Do I want it to start walking 2 miles in a month? Or how long do I want it to go? How long can I read, how long is it that I want to set to have the outcome of this goal? So, and then planning is another one. What interventions are appropriate for, in order to meet these goals, okay? So even on your test, thinking about your test, and we're talking about psychiatric issues, again, when you think about Maslow's, we're gonna be thinking about things, hopefully, that has to do with the safety of that patient. How can we provide safety for this patient, okay? All right, let's take, y'all want a 10 minute? 10,